So what do you think I'm doing well so far?
I think that you're asking questions that are, you're not just asking questions, ask questions. So I think a lot of the questions that you're asking are pertinent to what you're observing, what you're seeing relevant to our practice. And so I think that's helpful. I think it's easy to just ask questions to try to just,
Fill time.
And, I think by asking questions that are pertinent, you're going to gain more out of the experience. I think you're doing great here. You're showing great initiative in terms of room and patience and learning that process, and just the little things. You're jumping in. You're not shying away from that. It's easy to stand over in the corner and just be like, oh, I don't want to I don't want to mess anything up, or I'm afraid to do that. And you're not doing that, which is it's nice. It's kind of refreshing actually to be like, yes, go get her.
Cool.
So,
What stuff that I can improve on for these next couple of weeks?
I think constantly just confidence. Always working on your confidence. The numbers highlighted on the back of the call. Thanks, Tony. Always working on your confidence, and that comes with doing repetitive things. And so we'll start working more on your evaluation stuff, letting you get in, get more hands-on. We'll start with the younger population because that's, I think, a comfort level for you. And then you'll get, there'll come a point where I'll be like, hey, let's look at this, and I'll have you put your hands on like an 80-year-old and be like, ah. But I think that will build that confidence, because you'll finish that and be like, it's really no different than a 14-year-old. Sometimes it's easier because they actually will relax and listen to you, whereas youth is like, just basket sometimes.
So what are some soft goals for my week 3 kind of stuff?
I think one of the things that we talked about earlier this week was letting you, start doing some more hands-on. Letting you start doing, whether it be some palpations like today with that clavicle fracture, letting you start doing that and getting comfortable with those interactions. I think describing is starting to work on how you're structuring that. And it's challenging, right? So part of it is, as you're working on clinical notes, is listening and what you're hearing and putting it in. Part of that also falls on being able to arrange it in your mind in a sequence that's kind of consistent with flow of an evaluation, if you will. I think it makes it easier for Dr. Mahaffey to read. And so we can work on that. I can show you some of mine. We can look at some of the stuff that you're doing and see here, like verbiage and learning, how we can use, maybe more terminology that's applicable to medical.
Yeah, my professors, they always got on to me because I would say slight pain, excruciating pain. They're like, stop using adjectives.
Yeah, just little things. That comes with practice as well. And I know one of the things you asked me is how did I learn with SOAP notes and stuff like that. And I learned from reading. I was very lucky that where I was at, when dealing with the athletes and the patients that I had, I got to see all their clinical notes come from orthopedic surgeons and primary care. I would read those, one, because it was my job to know what was going on with them, but by reading them, it allowed me to learn that language and kind of start building that into my vocabulary. So, instead of me going in and saying patient doesn't know how the knee started hurting, I can say patient reports insidious onset of knee pain. It's just a more concise way of wording it, and just flows better.
That makes sense.
And you always got to be mindful of insurance. What are the things that insurance is going to be looking for? So we can work on some of that and some of the things of when we're looking at different body parts and we're putting notes in, what's going to help the doctor, what's going to help guide him. Because part of our job as well is to help guide them. Give them pertinent information, things that are going to help them make a clinical decision on how they want to treat that patient. It's ultimately their decision, but if I can help, make that decision easier, I'm going to do that. And that's
That
where,
makes sense.
our judgment and our experience comes in as well. It's part of the reason they hire us. Not just to push papers and, do rooming and all that, but really our expertise on, hey, what are you seeing? What do you think? Sometimes they'll be like, I didn't think of that. That's a great thought. Let me go look.
So, just to recap then, continue to work on documentation, maybe start to do palpation going into week 3.
Yeah.
Okay.
Yeah, I think that, and we can work through special tests. It's something where, I always like, you can quiz me on special tests because it keeps me, up to speed. But,
I'll pull up my special test stuff and I can review and
and then hopefully we get some more unique things.
Okay. So what cases have I seen this week? Well, this week it was really cool with the clavicle. That was really, really cool.
Yeah.
Anything I didn't understand? I was telling Dr. Mahaffey this. It is very different from I learn X, Y, and Z in class, but it's not always X, Y, and Z. It's something different. It's something that's like with the pes and serine tendinitis. I was like, we only really talked about a bursitis, not. I didn't even know that there could be a tendinitis of a group of muscles.
Yep, sure.
But I guess because they all hit there.
Yeah.
So it's just strange.
Yeah, I think I always try to have a very broad differential in my mind. And then if I can narrow that down with my clinical skills and my evaluation skills, one, again, a good history, listening to them, that's going to lead me to a certain stop. But then from there, I've got to decide, do I want to go left or right? And that's where your clinical skills, special tests, looking, all of those can help. And even then, you're right, it isn't always left. It might be right, and vice versa. So,
Can you log out of her chart?
yes.
Sorry.
Sorry.
I'm good.
Out.
It's like, do you want to be on the YouTube video?
Oh, I'm good for that. At least two or three times a day.
Okay, and then any other general feedback that you want to give me, or just going back?
No, I think you're doing great. I think you have a natural likability when you go in the room that the patients are going to relate to you. And I think that's your personality, and I think that is an asset. I think there are clinicians that practice in medicine that don't have a good bedside manner, and patients can pick up on that real quickly. And so I think that's an advantage that you have right from the get-go, is that you can walk in a room and instantly have a connection. You do a fantastic job of relating to the patient from what I've observed.
Thank you.
And, relating some sort of a personal, whether it be, where they're, doing a swimming class or, and one thing I've noticed, and it's actually kind of nice, I kind of was telling Matt or somebody the other day, I said, gosh, I wish I had you in every injection because you're a great distraction to the patient because you have an easy conversation with them. And when it's just two of us, sometimes, we're focused on doing the procedure, it's hard to sometimes remember and be like, hey, it's okay, breathe. So I think they're doing great with that. And again, I think your willingness, to one, step out of your comfort level, right? So you're seeing a patient population that you're not used to in the older people, and you're seeing things that you typically would not see in an adolescent, high school, or collegiate athletic setting, right? You're not going to see osteoarthritis of a hip or a knee, or hand or wrist joint in the population that we typically, the traditional athletic training model. So I think take all that in because it's a great experience that you can take wherever you go. You can always, if you go work with high school athletes or college athletes, you can always remember that knee injury, you're gonna, you have a good idea of what it's gonna look like 20 or 30 years down the road.
Yeah.
Because you're seeing it.
It was cool with the ACL guy. It was
Mhm.
very cool. How I'm never, like, I'm so used to just seeing them happen when they're young, and it's
Yes.
like, okay, you go get surgery, but I forget that you have to live with that for the rest of your life. Like,
That's right. That's right.
That
You're,
didn't
no,
even
you're right.
cross my mind.
And you see it from this end, and then you know
Mhm.
here's a guy that comes in 20 years post-surgical. And,
That's crazy.
You know, like, so. I believe it is. Yes, we do. I have
Mhm.
it. I think I have it. So.
Tony, do you have any feedback for me for things that I'm doing well or need to improve on going on to next week? You don't want to be
Bring-
like.
what? What's that,
You
bring
can just
donuts?
speak loud.
Oh, okay. Yeah, you're doing a good job.
Thanks.